I'm Stephanie. I'm a senior technology reporter at BuzzFeed News, based here in San Francisco, and write about health startups of all kinds, and it's great to see you all. We're going to have a lively chat this afternoon about a really important topic, which is preventative healthcare. So much of the health industry historically is about treating diseases once they're full-blown, or through medications or surgery or other invasive procedures. But what if we tried to prevent diseases and chronic conditions from happening in the first place? Like, what a concept. What if you could modify your behavior and lifestyle to make that happen? And then what if we use technology to try to help you do that, right? This is a very timely topic, I think, because in the last couple of years, preventative health has been a focus of the Affordable Care Act, which may be RIP at this point in the afternoon. I don't really know.
They delayed the vote.
Oh, they did? Oh, okay. So it lives another day. And at the same time, that's happening. We have this sort of explosion in artificial intelligence and machine learning, and I don't profess to always know what those terms mean, but certainly they are a huge force in the industry right now, so I'll try to talk about those things, maybe using a minimum of buzzwords. So I don't know if we're going to come up with an answer what's going to happen to the ACA by the end of this panel, but it's going to be a good talk, and then we'll have an audience Q&A, so be sure to think of some questions for these guys. So I'm going to start with you, because you're sitting here. So this is Sean Duffy, the co-founder and CEO of Omada Health. So Sean, your company took a body of research that showed by going through a certain program and focusing on things like weight loss or reducing blood sugar, people could reduce or eliminate the risk for prediabetes. So how does that work exactly? And then how does advanced computing techniques and data science come into that?
Yeah, for sure. So hi, everybody. I'm Sean, co-founder and CEO of Omada. So there's an incredible body of face-to-face research that shows that intensive programs can help delay, postpone, sometimes reduce, and eliminate entirely the progression from prediabetes, where the warning signs are there, but you're not quite type 2, into type 2 diabetes. And funnily, clinically, it's deemed as the right approach. There's, if you look at what all the academic societies say, like the ADA, American Heart Association, United States Preventive Services Task Force, they all say that the next step to someone finding out that they're at risk should be an intensive program. They've been very tough to scale. So that's been Omada's mission, from the beginning, and we view it as a mandate because for the first time in global human history, preventable chronic is killing more people than infectious. So, at Omada, you can almost think of us as like a little digital hospital that provides this intervention. We take people at risk, we match them into groups, we get them connected hardware, we kick them off on a timeline with a health coach. Week by week, we bring people through curriculum. There's kind of shared goals and kind of a narrative that people go through. And it's, we've shown it to be effective. We've published 7 peer-reviewed papers, and the way we fit, we actually contract in the healthcare system, kind of like a hospital.
Yeah, so part of your program involves coaches, right, who give people feedback on their exercise and behavior. How time-intensive is that? And in keeping with the theme of this, is there a chance that they could be replaced by AI one day?
Yeah, I mean, I would say it is relatively time-intensive. I've always felt that we're not quite there yet on the AI front. I don't think, we're still in the very uncanny valley. Where at the end of the day, knowing that there's a human rooting for you, supporting you, there to help you, when you slip, to bug you if you didn't do your lesson, I think is mission critical. Yet, what we've done at Omada is really use data science and machine learning to almost make them superhuman. So, every morning a coach wakes up, there's like 60 suggestions that our data science team has fed them based on every person's kind of behavioral trail in the program of people they might kind of reach out to, say hi, and we tell them why we think that'd be a good fit, but we let them be the judge of that. And I think for the foreseeable future, that's how we want to carry it forward. More likely if there were, I guess, a canonical AI component, it would be like a member of the group. That would be kind of like our version of I hate to use the word clippy, but like our version of like a personified bot that helps chime in.
Oh, like the Microsoft word clippy.
Yeah,
I
exactly.
understand now. Got it. So Michelle, your mission is not dissimilar, I think. You work with people to have health goals, and how do you go about doing that? This is Michelle Snyder from Welltok.
Hi everybody, Michelle Snyder. So how do we go about helping people meet their health goals? Yeah, so it's an interesting question. I mean, I think a lot of it does start with data. So we're a consumer health platform at Welltok, and what we do is bring together different programs and resources for individuals and create personal health itineraries for them based on their individual needs, interests, goals, etc., and then reward them for doing things related to their health. So going back to helping them, right? So we create these itineraries, and we try to bring, using data and analytics, help figure out for the population health manager, so we sell it to health plans, employers, etc., who's at most risk, who's most likely to be impacted, and who's going to be most receptive to the different programs. And so based on that, we serve up different programs and resources to different people. And I think that's one of the things that's made us so effective. We did a large survey with National Business Group on Health last year, and surveyed thousands of employees. And the two reasons why they weren't participating in programs related to their health were either they were lack of awareness or lack of relevance. So I think there's a lot you can do in terms of awareness by making sure you're using the right communication channels to get to the people at the right time. But then there's lack of relevance, and to me that's been one of the big issues in the healthcare industry is typically, a health plan or an employer might have a portal, and everybody goes to that portal and sees the same thing. But I'm gonna have very different needs than the employee who's sitting next to me, my colleague at work. And so when somebody comes into our portal, I will see very different things than, for example, Stephanie or Sean, because we have different interests, motivations, health histories, etc. And using data in that way to create a more personalized experience, I think is really key. And then going to your question about artificial intelligence, we can talk about it later, but we were one of the first companies to partner with IBM Watson in the consumer health space. And it's hard. We're still not there yet. I mean, I think we're still 5 to 10 years out in terms of really leveraging artificial intelligence and cognitive computing, but I believe there's so much that can be done, and I don't think it's ever going to be a replacement for doctors or even programs like Omada, but it can be a complement because there are oftentimes people just need answers to questions and need some support at times when they may not be able to access the right people or tools.
So for those of us who haven't used Welltok, can you paint us a hypothetical example of someone logging on, and how personalized are these healthcare plans that they get?
Yeah, so for example, if there were 2 employees and one person was diabetic and had an elderly relative who needed help, and maybe you knew they had children and they were having trouble sleeping, versus somebody else who maybe had COPD and said they were very stressed and also said they were having financial difficulties, their itineraries would look very different. So the latter person, there might be some financial programs that their employer has contracted for that we could serve up. They might be sent to Propeller Health, one of our partners, who has COPD program, and they might, I think I said stress, be put into a stress management program, where the other person might see a diabetes program, might have some tips on nutrition and sleep, etc. That's how it would look differently. And then those people also could get rewarded differently, right? So based on what their employer or sponsor wants them to do, there might be different values assigned to doing those programs.
Cool. So Stephanie Tilenius is the founder and CEO of Vida Health, and you also have a mobile coaching platform where you work with people one-on-one. Can you tell us a little bit about, as a consumer, what you would expect to see when they join your platform?
Sure, so we're mobile first, and you come in and we enable you to match to a coach, sort of personalized, much like the way Michelle's describing. So we'll do a health risk assessment and really understand where you're coming from and where, there's 130 million people in the US that have a chronic condition, and most of them, 50% of them have like 2. So we'll really target the programmatic approach we take. We'll match you with a coach that we use an algorithm and a bunch of data to actually figure out the right option. We give you 5 choices, and you pick from that coach, and then we also have clinical evidence-based programs like the DPP and others. And we'll look at someone and help them manage diabetes or prediabetes or hypertension. So we've had lots of people reverse chronic conditions entirely. So for example, we had a 49-year-old mom recently who lost about 70 pounds and went off all her meds, cholesterol, diabetes, and blood pressure meds. So we help people transform their lives, and it takes time, but I think I agree with Sean on your question earlier, like you need a human involved. I think we use machine learning and AI. The AI is really not AI yet, but we use a lot of data and technology, but I think the human element is really important.
Yeah, so from what I understand, you have something called the Vida bot, which helps.
We do have Vida bot.
So how does that work, and as a customer, do I know if I'm talking to a human or a bot?
Yeah, we are very careful, and the Vida bot is branded Vida bot, so you know when you're talking to a machine versus a human, and it's very important to distinguish between the two.
And do people respond better to one versus the other, a human versus a Vida bot?
They respond to both because they're used for different purposes. So Vida bot is much more reminders, kudos, scheduling, lots of basic stuff that you would expect a machine to do, whereas the coach is really providing more of the qualitative advice.
All right. And so Peter Hames is the CEO.
Oh, hello.
Good. Of Big Health, and we've been talking about physical activity and exercise and being active, and your platform, Sleepio, is about the opposite. It's about sleep.
Doing as little as possible.
Doing as little as possible.
Not quite. So hi everyone. Peter Hames, co-founder of Big Health. We are a digital medicine company, by which I mean we are taking evidence-based behavioral therapies with a focus on mental health, and then automating them, thereby making them as scalable and consistent as drugs. And so, unlike I think some of the others on this panel, my view is that by going automation first, so as in removing the humans from your first principles, there's an opportunity to use these novel devices, novel methods of modalities of treatment to produce something completely different that still stands on the shoulders of giants, in terms of the evidence that's there. And so as you say, like our first product is Sleepio, ostensibly a digital sleep improvement program, fully automated, features these evidence-based CBT techniques, and as with any other sort of medicine, thoroughly evidence-based. So we have conducted now 18 peer-reviewed papers, 5 randomized control trials, all supporting the fact that the outcomes are comparable to face-to-face therapy.
Right, and so the way Sleepio works is you enroll if you have sleep problems, serious ones, and a cartoon teaches you how to address those.
Exactly. Your guide is an animated virtual sleep expert called the Prof, and his narcoleptic dog Pavlov, who leads you through the program. So bounds on and falls asleep mid-bound. But unlike a human, he's there for you 24 hours a day, right? So if you wake up in the night and you can't sleep, you get Sleepio up on your phone, the Prof appears in his dressing gown. It's like, Stephanie, what seems to be the problem? You can't sleep. Let's get you out of bed, have a look at your relaxation plan. Might play you some relaxation audio. And again, by virtue of all of the passive data that we can now collect through your mobile device and through other devices that we might import data from, we can then tailor the reminders, prompts, triggers to your particular schedule. So he can check in the morning, send you an SMS after you've woken up and said, so sorry you woke up last night. Happens to the best of us. Fill in your diary while it's still fresh in your mind.
Well, it's funny because I always thought that advice for falling asleep was to not look at your phone, but here's the opposite,
totally
I guess.
Wrong. No. So you're absolutely right. That is attention.
Yeah.
But he, I think the majority of the work that he does with you is while you are alert.
Right. So if you come into the program with sleep problems, that you have a hard time falling asleep, what is the preventative aspect of your program?
Yeah, so I think that you can think about, sleep in itself as a sort of as a good, a vector and target to engender, preventative care. So I think this relates to the wider question of how to engage a mixed population in some of these health issues before, they're bleeding, or before it's an acute issue. And, we have very consciously focused on sleep as a horizontal, not a vertical. People think in terms of complaints. I'm not sleeping well, my mood is low, not syndromes. And so I think to engage people at a sort of pre-medical stage, it's very helpful to relate to those symptomatic complaints. And so when we go into a population, we actually address 100% of the population. We say everybody sleeps, as far as we know, and so it's relevant to everybody. And so from that engagement, we can then triage you based on the level of your sleep score into the appropriate level of help. Mm-hmm. But we do know that poor sleep is predictive of a whole array of mental and physical issues. So by using sleep as a marker, we can, in a very destigmatized way, find people, a subpopulation who are above average risk for depression, anxiety, these much more stigmatized issues.
Great. I want to talk a little bit about automation. And so your program is fully automated. You're working with IBM Watson. I've heard comments that AI is not fully there yet. Can you describe, if at all, what that means a little bit, and where it actually is right now in terms of helping replace some of the human labor?
Yeah, I mean, just from our perspective, so the interesting thing about using Watson, right, or cognitive technology is that it takes a lot of effort to train, right? So Watson in itself is just, a thing, right? And you have to train it. So our first actual, product that we launched using Watson was called Virtual Benefits Agent, and it is a way for people to ask Watson questions about their benefits, right? How much money do they have left on their deductible? Who's in their network, et cetera? What's covered? But the thing is, it has to be trained, and then people have to ask it questions. And Watson gets smarter over time. And so that's really the interesting thing, I think, about using cognitive computing technologies. It's not like typical product development where the product is ready to launch and you launch it, right? And right out of the gate, that's the product, right? It evolves over time and gets better and better. And I think a lot of times you hear comments about how it's not quite there yet. It's that you have to continue to train and refine and feed it, figure out if you're feeding it the right information. And if you're not, figure out what information you have to feed it to get to the right answers. And so that's how I would talk about it. It's kind of a continuous process.
Got it.
And I would say, I mean, when I shared skepticism of AI, that's for what we do, which is a very behaviorally forward intervention. It's incredibly difficult to get any outcomes in the lifestyle intervention space, to get any population at large to lose any amount of weight at a population level is really, really hard. It requires an ultra heavy instrument. I think, people for us are a heavy instrument. I think there are many, many applications, like Peters and Big Health, where automation is absolutely possible. I mean, the proof is in the pudding, right? 23 peer-reviewed studies. And then the other, but AI generally in healthcare, I actually think the best use cases for AI are probably not in the behavioral space necessarily. I think they're more in, precision genomics, things where the data's a little more at reach. It fits kind of what AI can currently do a little bit better. And I think that's where we'll see the first breakthroughs.
Yeah, I mean, just to put it in perspective, machine learning is used by probably all of our companies, right? And that's standard technology. Google, a lot of Facebook, everyone's using machine learning, and there's a lot of applications that are baseline that we can all use. AI, you're talking about replacing humans and using data to replace humans over time, and that's going to take time. Even Facebook Messenger, 75% of the AI calls they had to use a human to review them. We're not there yet, right? So there's some, sense that AI is like fifth grade level thinking right now, from a computer to actually handle. So it's going to take another 3 to 5 years before the AI replaces the human.
Okay.
Yeah, I'll just add to that. Although our platform is fully automated, I would tend to agree that right now, ML is a tool. It's an optimization tool, and you still need, humans to design the framework within which that can do its work, and garbage in, garbage out. If you misdesign that, then although the possibilities are huge, it's not going to be of any use to you like any other tool.
Right. I think we have time for maybe one audience question. Or I can just ask you another question.
Hello, hi. Thank you all for being here. So in helping my family try to adjust their behavior to be healthier, it seems like beliefs and emotions and other, I don't know if they're qualified as social determinants like your income, are a big factor. So can you say how maybe you address all those layers, or are there certain types of diseases or populations or obesity or something that's more attributable to certain types of social behaviors and that kind of thing? Or
you do have to address social behaviors. We have one employer where they're a manufacturing operation and they're in Alabama, and it's a food desert, right? So we had to work with HR to figure out how to solve for that. So, and I'm sure Sean works with Medicaid and Medicare. I mean, you have to look across these populations and look at all the social determinants. And you have to pair coaches that match to that population, and whether they speak Spanish, what level of grade, reading they're at. It's a complex matching program.
Yeah, I completely echo that. I mean, we have a low literacy version of the curriculum. In our Medicaid safety net deployments, we work to match people together. We have kind of special health coaches we use to help provide a little bit of social context. And then interesting, I mean, demographically, the key trends that we see that relate to your likelihood of a positive outcome in our program are weirdly age. So older people actually do better in our intervention. For every decade of age, you get about an incremental % yield in weight loss at 16 weeks. We do see ethnicity differences. We do see socioeconomic differences. And you're always working to tune and tailor to address it, because they are absolutely real.
I was just going to make one other. I think it's a really interesting question, because we made an acquisition a couple years ago of a predictive analytics company called Preventative, and one of the reasons we did it was that if you look in the healthcare industry, for the most part, they're just trying to take claims and clinical data, which is retrospective, to kind of predict how people will behave. And what you end up finding is that probably 90% of the variables that are actually the most important to predicting how people will behave related to their health have nothing to do with claims or clinical data, right? It's some of the things you guys talked about. It can be your shopping patterns, demographic information, your voting behavior, things like that. So we have this database of about 800 variables that are just all these different public and private consumer variables that have nothing to do with health, that we then actually mix in with some of the clinical and claims information that then really helps us figure out who's at most risk, who's going to be most receptive, and who's going to be most impactable. But it'd be really hard for us to do that without these other variables that do not come from the healthcare system.
Got it.
Yeah. All right. Matthew Holt, THCB and Health 2.0. Hi to all of you. So we're talking about behavior change. You guys all know, the literature says that depression, mental health, and other issues are big impactors on that. If you're depressed, you're more likely to be sick, you're less likely to have this. And yet we've seen the development of a series of companies that do sort of mental health and depression that are not the four of you. Although you've got Mindbloom, Michelle, which is somewhere vaguely in that. I don't know where it's ended up. So should you guys be acquiring or buying or adding mental health? And where does mental health fit into this, other than if you sleep better, you're a bit healthier? Is there actually, for serious mental health, for getting really the root cause of these, where are you guys going to end up?
Peter?
So I think, you're absolutely right that there is this, a huge and very costly issue here around mental health. And the conundrum is largely how, as you say, how do you engage people who have these issues? We know that between, only a third and a quarter of people with these issues actually end up seeking help, let alone engaging and then being successful in overcoming them. And so I think, after you've engaged them, how do you actually then get people to do the things necessary to make themselves better? I go back to this point about complaint. Our view is that, and the evidence suggests that by using, in our case, sleep as a vector, we are able to lever significant outcomes in mental health. So 65 to 70% of depression and anxiety patients also suffer from insomnia. And what we've seen, there's an NHS clinical audit study that got published last year where depression and anxiety patients were only given Sleepio, nothing else. And they presented for care, not our data, NHS data, 68% of them moved to recovery for depression and anxiety. 68%, no humans, fully automated sleep solution. So I think, in many ways, because of the interrelatedness of all these issues, we already have a mental health solution, but without the stigma. And I think that in terms of ongoing development, you're absolutely right. Not everyone with a mental health issue has sleep problems, and we are looking to then expand what the prof can do, basically, like what his skill set is, to help you even if you don't.
Yeah, and I think for the right company you're offering, almost like as an adjunct for the subset, which is probably a lot of Omada's participants that really struggle with mental health, I think it would really help yield further outcomes in our program. It's just so interrelated.
Cool. Well, I got to end it right there, but thank you so much to the panel. Thank you guys so much.
Thank you.
Thanks, guys.